Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network, and we are here today to do a live support group meeting for IC. So today what we're going to do is we're going to cover the new Elmeron and macular retinopathy research, the tremendous conflict that creates in the IC community, especially patients who are relying on Elmeron as their treatment for IC. We'll be taking your questions on IC and all sorts of good things like that. So let's just wait a couple of minutes and let people come in. We are simulcasting live on Facebook and YouTube. I see 3 people over on YouTube right now. Hello, Facebook. As always, if you have questions, hi, Jamie. If you have questions, please feel free to write them in the comments. And we will take them. Oh, wait a second here. Hold on a second. I did it on the, give me a moment here, guys. We're going to do a quick repeat on that. Leave it to me, right? Leave it to me. Hold on one sec. Oh, you have to love the joys of technology. Hold on one sec. September 16th, 2001, 18. Yes, yes. I would love to say I'm technologically perfect every time, but I'm not. All right, so now we're going to go live on Facebook on the right page. Hello on Facebook. Hello, hello. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. We are here today to do a live support group meeting for IC. Yes, indeed, we are. It is September 16th, 2018, and we are going to be talking today about the Elmeron eye research. Hello, Lindsay. Hello, Sherry. Very, very nice to see you. As always, my friends, you are absolutely welcome to put questions in your comments, and I will take them while we can. Jamie, I would absolutely love to talk with you. Hello, Gina, over on YouTube. So, guys, we are simulcasting live on YouTube and on Facebook. If you see my eyes moving, that's because I got YouTube over here, I got Facebook over here, and I will eventually try to merge you. But in the meantime, let's wait a couple of minutes. We'll go ahead and let some people come in, and I've got some fun things for you too. I just need to clean up one thing here real quick. So let me do that. Good grief. I hope you guys are having a good weekend so far. I've been having a pretty good week. I was able to go work out yesterday. That was very cool. Get outside. I liked it. All sorts of good things like that. Alrighty. Okay. That is done. Excellent. Right. We got 15 people on Facebook. We got 6 people on YouTube so far. Let's give it a few more minutes. Kelly, thank you so much. Yes. I have a tradition, and that is I get very, very dirty on Saturdays out in my garden, and then I wash my hair. JJ is walking on her treadmill or his treadmill while in the meeting. That's great. Hello, Catherine. Hello, Kelly. Hello, Sandra. Hello, Sarah. As always, guys, you are at, okay, let's try to reorganize my screens here so my eyes are not going all over the place. There we go. I think that's a little bit better. Okay, so my friends, I have something for you, and that is, if you send me an email, I'm going to give you something. This is September is IC Awareness Month. Hopefully you've already been over to the icawareness.org website and you've had a chance to see what we're doing. We happen to have an IC Awareness bracelet, right? Oops, hold on. It says, "We stand together," because hello, we stand together. This is a bracelet we've had for many, many years now. If you send me an email right now to IC Network at Mac, that's M as in Mary, A as in C, A is in Apple, C is in Charlie, icnetwork@mac.com. I am going to send you a free IC awareness bracelet, and I'm also going to send you our new food card. We have our new food card, which is usually bladder-friendly foods and foods to avoid. icnetwork@mac.com. If you go ahead and send me an email to that address, and I'm going to send you free as a gift for IC Awareness Month. In honor of IC Awareness Month, I'm going to send you those. Alrighty. Let's just wait a couple more minutes here. Now listen, guys, I have a goal with these meetings. My goal is to make you so strong, so powered, so informed that you can walk into any doctor's office with your head held high. I don't want you to take any disrespect, but I want you to treat people with respect, but I want you to be able to very confidently address a situation if anybody has the audacity to tell you that IC is not real, or IC is in your head, or that your pain is in your head, and all that sort of stuff. So how do we do that? We make you so educated, so knowledgeable, so informed that you can kick ass when you go to any doctor's appointment, right? And that's our goal here. Even more so now with this new Elmeron research that's come out. It is stunning to me. It was a very difficult issue for me to raise. I knew I was going to potentially put myself up even to litigation. But as soon as the researchers of the Emory Eye Institute said that patients with eye issues should stop using Elmeron, I knew that I had to do a story on it, and that is why I did. It might be a little early, but it doesn't matter. I've already gotten some good phone calls. So I want to dive right into it. Okay, we're going to dive right into it. So I've got my articles right here. So let's talk about what happened. 2 weeks ago, I was cruising the National Library of Medicine and the Journal of Urology looking for articles to do on IC, because the IC Network is, in fact, a medical education company, and we write a lot of articles, right? So if you haven't been over to the IC Network page yet, please come on over, ic-network.com. We are rated #1 in the world by Harvard Medical School and the University of London for our work on IC. We've been doing this for 25 years. I should also say that I have 3 college degrees. I have a degree in chemistry, I have a degree in drug science, pharmacology, and I have a degree in psychology. I'm also a presidential fellow, which means that the White House named me a presidential fellow many, many, many years ago. But it was a wonderful honor, and I'm more than happy to brag on it, just a little tiny bit. All right. So I take my job very, very seriously, and I'm very blessed and lucky that I've got some good degrees that help me understand research. So imagine my surprise 2 weeks ago, as I was cruising through the National Library of Medicine looking for articles on IC, when I came upon a little tiny letter to the editor to the Journal of Urology. And of course, when you're on the PubMed website, which is the National Library of Medicine website, you have to actually click over to the journal to actually read it. So then I went over to the journal and read it, and life has not been different. I mean, life is not the same since we've read this. Okay, so let me give you the context here. The Journal of Urology is the premier research journal for all urological conditions. And they've done some very, very good articles on IC in the last 25, 30, 40 years. So anybody in the know who wants to stay up on IC research, you come to the Journal of Urology. So earlier this spring, there was an article called BRUDAC, which was on new clinical trial criteria for IC, right? Very, very nerdy. I'm very nerdy. But it was interesting, written by Rob Moldwin and Curtis Nickel, 2 very excellent IC authors. So this little letter to the editor was in response to their article, right? And you have to remember that 99.999% of researchers and IC doctors will never see this letter to the editor. But I want to read this letter to the editor. So this is from a team of researchers from the Emory Eye Center. Now, the Emory Eye Center is part of Emory University, and they specialize in rare retinal diseases. They wrote a letter to the editor to this specific article to try to let the IC community know that they had found what they believed to be a new eye disease. Okay, so I'm going to read this to you. It's by Doctors William Pierce, Adam Haniff, and Dr. Nirav Jain. And again, they're of the Emory Eye Institute, or Emory Eye Center. To the editor, we read this article with interest. As mentioned by the authors, only 2 US FDA-approved therapies for IC currently exist. Oral pentosan polysulfate, which as we all know as Elmeron, and intravesical DMSO. We wish to alert readers to a concerning new observation of vision-threatening retinal changes associated with a long-term exposure to pentosan polysulfate. We recently reported our findings of retinal pigmentary changes in 6 patients undergoing long-term therapy with pentosan. These patients described difficulty reading, trouble adjusting to dim lighting, among others. Each patient had received a standard dosage of pentosan polysulfate ranging from 200 to 400 milligrams daily for a median duration of 15 years. For a cumulative exposure of 2.26 kilograms. That means that's the total amount of drug that patient has been exposed to over time. Examination findings in patients with this condition are suggestive of injury to the retina and underlying pigment epithelium. Although we have yet to establish causality, the presence of these highly unique retinal findings in this population demonstrates a strong association with long-term pentosan exposure. These cases were identified during a brief 2-year period at our university-based specialty clinic for acquired and hereditary retinal diseases, where we are accustomed to evaluating rare retinal diseases. After extensive investigations, which included molecular testing for hereditary retinal disease, we found these cases to resemble no other retinal disease. Furthermore, we are unable to postulate a pathophysiological mechanism linking IC-BPS itself to these findings. Pending further investigation, it remains unclear whether drug cessation will halt or alter the course of retinal disease. However, we encourage drug cessation in affected patients. Furthermore, we currently recommend that any patient with suggestive visual symptoms undergo a comprehensive ophthalmic examination with optical coherence tomography and fundus autofluorescence imaging, regardless of exposure. These recommendations will undoubtedly evolve as we learn more about this concerning finding and may involve routine surveillance, eye examinations at predefined levels of drug exposure. In the meantime, we are hopeful that ongoing investigation will yield additional therapies for long-term disease control in patients with IC. Okay, now let's just break it down here. So here it is. Here are eye doctors looking for a way to communicate to the IC community, IC urologists, the urology community, that they believe they have found an associated complication with the use of Elmeron. And it was a very interesting way to do it, right? But it was valid. It was a very valid way to do it. And of course, the Journal of Urology, no fools, decided to print it. Thank God they did. So whenever somebody writes a letter to the editor in response to an article, the article authors are allowed to respond before publication. So you've got the letter, which is potentially criticism of the article, and then you've got the author response rebutting their criticism. Of course, this wasn't critical of the article. This is, in fact, raising a new issue of eye issues with Elmeron. So doctors Rob Molden or Curtis Nickel, both or one of them, I'm not sure which, wrote a reply to this letter to the editor. And this reply is also powerful. So it's only two paragraphs. So I'm going to read this to you now, okay? Pierce et al. Are looking for a platform to let the urology community know about their observations regarding the long-term use of Elmeron and potential ophthalmological complications, so much so that they have used a letter to the editor concerning our recent article on the FDA BRUDAC guidelines. While their letter was nothing at all to do with our article, we are happy that they had a chance to present their observations. They describe a toxic maculopathy characterized by symptoms of difficulty reading and prolonged dark adaptation in patients on Pitocin for a median exposure of 15 to 16 years. The association is quite clearly laid out in their recent publication in Ophthalmology, and they continue to identify more cases in their clinic, as well as in other clinics, the clinics of their colleagues. Pitocin polysulfate, which received conditional FDA approval in 1986, has been prescribed to tens of thousands, perhaps hundreds of thousands of patients with IC-BPS. The optimal dose, pharmacokinetics, mode of action, and even efficacy remain unclear, although safety was never considered a major issue. Many patients with IC-BPS remain on this medication for years and even decades. It is quite unlikely that urologists treating patients with IC-BPS would have ever made this association. Even ophthalmologists have difficulty differentiating it from other similar macular disorders. Yet the implications are either frightening if our treatment is causing this condition, or instructive if this condition is a previously unknown manifestation of IC, and I'll talk about that in a minute. And then they talk about, we need more research. We need to validate this. I would propose a simple large-scale survey of patients with IC to determine the link between ophthalmological diseases and treatment modality. Okay, so let me repeat this. It is quite unlikely that urologists treating patients with IC would have ever made this association. Yet the implications are frightening if our treatment is causing this condition. Okay, so, and I will tell you, in all of my years, 25 years being an IC support group leader, 25 years studying the research of IC, we have never, ever, I had up to this point never seen any inference between Elmeron use and eye issues. Okay, so you can imagine as I'm reading these, I'm going, I'm cussing. Let's just say it's like, oh God, this is bad, and as soon as they said, the researchers from Emory said, we recommend that any patient with eye issues taking Pitocin stop the Pitocin, I knew that it was my duty to tell you about this. No one else is talking about this. I'm the only one that is talking about this, okay? And believe me, I don't want to be talking about this at all. So I then paid the $40 for their article. So they actually published their research last May in the Journal of Ophthalmology, the eye journal. And this is it's a stunning piece of work. So basically, they had 38 IC patients who were referred to their clinic for eye problems. Now remember, they're specialists in rare eye diseases. So these are patients who have already been screened by other doctors. Those other doctors have not been able to help them. And so they've been sent to a specialist. And so this specialist here we've got specialists who probably never even knew about IC, didn't even know about IC, but what they started seeing were patients who were referred over and over and over again. And then they noticed, wait a second, these patients have all been diagnosed with interstitial cystitis. Well, that's interesting. What's IC? And what they were seeing was pretty profound damage to the retina. And I've got some pictures here. Let me give you some pictures. So these are different ways of visualizing the retina. And let me explain here, a maculopathy, the macula is the center of the retina. It is the part of the eye associated with fine vision. So it's the one that really lets you see details, okay? So let's take a look and see what was happening. So this is a patient over time. So at the beginning, they had little disruptions of their pigment in their retina. And then at their next appointment, it got worse. And then at this appointment, you can see it's pretty widespread. Here's another example using a different method of visualizing. So this is an early one, early picture, middle picture, and then late picture. So they had 38 patients. Now, they had 6 of those 38 patients that they had done extensive testing on. And so this paper is what we call a case series. It is not a case study, which is of one patient. This is a case series. This is 6 patients that they decided to share the data from. And again, these were only patients reported during from May 2015 to October 2017. Guys, just so you know, I'm not quite looking at your questions yet, so please be patient with me. Of these 6 patients, age 62, age 60, age 46, age 60, and age 37. That's patient number 4. And while, yes, the average length of use was 15 years, I want to talk specifically about patient 4. Because patient 4 was diagnosed at the age of 24. She was given Elmiron when she was diagnosed. Just 6 years later, at the age of 30, she started having eye issues. And now in this study, she's 37, right? She's 37. And in fact, those pictures that I showed you were her. It's very interesting that the youngest patient in the study who had the least amount of exposure, at least in this study, had the worst damage. She has the worst damage. So again, so what were their symptoms? Their symptoms were difficulty reading small print, difficulty walking into dark rooms. So you know how if you're at the movie or you're going to the movies and it's really bright in the lobby and then you walk into a darkened movie theater and it takes a while for your eyes to adjust so that you can see the seats. Well, somebody with this, it takes much longer for their eyes to adjust if they adjust at all. And I got that from another IC patient who watched my last support group meeting on this, where we talked about this. And she is one of these patients. She's very clearly one of these patients. Younger, I think she was in her 40s. She's been on Elmiron for about 14, 15 years. For the last several years, her eyes have been getting progressively worse. Her first symptom was difficulty reading. Her second symptom was difficulty in low light. Her diagnosis is, in fact, pigmentary maculopathy, which is exactly the diagnosis that they've used in this study. And she called me on Friday and said, thank you, God, for telling me this, because you might have saved my eyesight. Because again, what do the Emory researchers say? If you are having eye issues, they want you to stop the medication because they believe that over time, the problem worsens. So what do they think it is? They think it could be a toxic metabolite of the Elmiron, a toxic metabolite accumulating in the retina, in the cells of the retina. That's one guess. Now there's still, this is very new, very early. They are in Emory. The Emory Eye Center is now in the process of doing much bigger research. We are helping them do that research. We are also doing our own research. While I have heard at least a couple of doctors are discounting this because it's quote unquote 6 patients, you have to understand that they actually had a group of 38 patients to start with, but they're now seeing more. And we're now seeing more. We're now seeing more reports of patients taking Elmeron who have had eye issues. Let's see here. I will tell you that every single one of these 6 patients underwent extensive testing to rule out hereditary pigmental diseases or retinal diseases. They had next generation DNA sequencing tests. So look for pathogens. If you've been in these before, you know we're talking a lot about next generation testing because that tests for the DNA of potential bacteria or fungi. Very now common now in IC patients who suspect that they might have chronic infection. I'm happy to talk about that later. Nearly all eyes of these patients showed subtle parafoveal pigmented deposits at the level of the retinal pigment epithelium. So they all had something in their on their retina, or almost all of them. I'm just looking for good pictures to show you. Okay, so here's what blew my mind, right? And so, again, these researchers at Emory are, state-of-the-art researchers. So they did their due diligence. They were trying to, again, as they're looking at these patients, trying to find a connection. Why would a group of IC patients have this issue? They dug deep into the research. And what did they find? They found an early Elmeron study, which was part of its clinical trial approval process or FDA approval process. And this shocked me. I had never seen this before. So they found an early clinical trial of Elmeron of 2,499 patients who received the drug for up to 4 years. So this was back in the 1990s as part of the FDA approval. And in that study, there were vision-related eye side effects, including optic neuritis, amblyopia, and retinal hemorrhage. So they found other Elmeron research that showed eye problems. I had never seen this study. So then the next question is, okay, and any good researcher and any good clinician is going to ask this question. Well, maybe it's not the Elmeron. Maybe it's part of the IC. Maybe it's just something new they've never documented in IC before. But that argument is very quickly discounted. Number one, because we have millions of IC patients and retinal damage has not been reported to any great degree. But number two, you think about it, you think many of us have a bladder injury or pelvic floor muscle injury, and some patients have bladder disease, like patients with Hunter's lesions. Is there any biological process which connects bladder function with the retina? And the answer is not that we know of. It's almost impossible to fathom that the bladder would have any influence over the eye directly, or that the eye would have any influence over the bladder. I don't believe that that's possible. And I think that most credible researchers would also go, yeah, boy, that's a real stretch. especially also when you look at, let's see, how do I want to say this? Let me say it a different way. When I got this, we immediately did a survey. Dr. Robert Muldoon reviewed our survey just to make sure it was pretty accurate and reliable. And we now have, I can tell you how many we have right now. Let me take a look here and I'll tell you how many have done our survey for this. Let's see here. I'm just logging into our software here. All right, so we have 400 patients who have completed our Elmeron eye survey so far, and I'm hoping many more of you will do it. We really need thousands of patients to respond. And it's 50-50. 50% of the patients who participated in the study who are taking Elmeron have had no issues with their eyes at all. They're fine. But 50% of the patients who have taken Pentosan have had, I take that back. It's now 53% report that they have had eye or retinal issues, 47% who say they have not had any eye issues. So to me, of course, that's early data, but that also creates a pretty compelling case that we've got something going on with this. And we are sharing that data with Emory University. We are also going to be facilitating their research so that we can really develop this data more fully. What symptoms are reported in our survey? Difficulty reading. 56% difficulty reading. 50% difficulty with low lights. 26% dimming vision. 60% blurry vision. 15% blank areas of vision. Okay, and this was again a patients who have taken Pentosan for a longer period of time. The other thing that is I think quite interesting is we now have 27 patients in our survey who have been diagnosed with macular degeneration. And that's one of the diagnoses that is potentially being missed here. What they say here in this study is these early findings resemble those seen in macular degeneration, pattern dystrophy, and common forms of macular disease. So when you have a 35-year-old or a 36-year-old diagnosed with macular degeneration with no history, no family history of macular degeneration, that certainly is going to get our attention. So, and since then, I will also tell you that I have had about a half a dozen phone calls so far of patients who heard about this, who called me, who were in the process of being diagnosed with other eye issues and things like that, in addition to the 400 who are participating in this survey so far. So, what does this mean for you? What does this mean for you? Well, number one, if you're taking Elmeron and you're having any eye issues at all, the Emory doctors want you to go to an ophthalmologist and have a full eye examination. Like immediately, out of an abundance of caution, do it. Do it. Let's take a look and let's make sure that you're not having early signs of any retinal issues. The second thing they say is if you are having eye issues and taking Pentosan, they recommend stopping the medication. And at this point in time, out of an abundance of caution, I agree with that. I agree with that. Until we have more information, we want to potentially save your eyesight. Right? Now, again, this is early. We cannot say for sure this is happening, but I'll tell you, the association between long-term Pentosan use and retinal disease is getting stronger by the moment. And so, again, out of an abundance of caution, it makes sense to stop to stop it, period. So the question then is, well, what do you do? So let's look at, so I've had a couple of patients say, but it's the only IC treatment. And my answer is, no, it's not. It's not the only IC treatment at all. At all. The first thing you got to remember is Elmiron came into popularity 20 years ago when we were thinking IC was a bladder disease. But we've learned a lot in the last 20 years. We don't think of IC as a bladder disease anymore in any way, shape, or form. We think of it more as a syndrome, a bladder pain syndrome or a pelvic pain syndrome. Why? Because other structures in the pelvis are also involved for many, if not most, patients. So we know that there's a big group of patients who have pelvic floor issues. They've got pelvic floor dysfunction. We know that there's another big group of patients who have central sensitization. Not everyone has a bladder coating issue, although certainly quite a few do. So as you're pondering what to do next, the first thing you really need to do is familiarize yourself with the IC subtypes, because it's really the subtype that's going to determine what the ideal treatment for you is. And let me just say this again, guys, for those of you who came in, if you send me an email to icnetwork@mac.com, I'm going to send you some IC awareness bracelets. See, I was wearing mine, took it off. I'd be happy to send you IC awareness bracelets, and I'm also going to send you our new diet card. Alrighty? Whoops. Can you see that? A very quick. We're also doing this in other languages too. So, okay. So, getting back to treatment. Elmiron is not the only treatment. Today, we're doing something called subtyping, because we know that a one treatment fits all approach does not work. We know that Elmiron does not help a lot of patients. I've seen this, I've been a support group leader for years. Okay, so the question is why? Because there's tremendous diversity in the IC patient population. You got some patients with Hunner's lesions, really profoundly, badly damaged bladder walls. Others with completely normal bladder walls like me. Both of us diagnosed with IC, yet clearly we are very, very different. You got some patients with terrible pain, others with no pain. Both could be diagnosed with IC, yet clearly they're very different. You got some patients with a lot of related conditions, others with no related conditions. Both could be diagnosed with IC, yet clearly they're very different. You see the diversity even more when you ask patients what began their symptoms. Because for some women, IC begins after having a baby. For some men, IC begins after riding a motorcycle for a long period of time. For some people, IC begins after chemotherapy or radiation. For others, IC begins after exposure to some sort of infection, an STD. For one very small group of patients, IC can begin after sexual abuse. For other patients, IC begins in childhood and is inherited. Clearly, we're not the same. A one treatment fits all approach does not apply in that situation. So we're doing now something called subtyping. And I've talked about these in depth in other meetings. I have a video on it. Just going to go through this real quick. Subtype number 1 is Hunner's lesions. These are areas of deep, profound bleeding in the bladder. These have now been connected to potentially 3 viral infections. Hunner's lesions require lesion-specific therapy. You cauterize the lesion, you fulgurate the lesion, you inject a steroid into the lesion, or you do Lyris. Elmiron does not work if you have Hunner's lesions. We have no research showing that Elmiron works with Hunner's lesions. What works with Hunner's lesions is lesion-specific therapy. So if you're taking Elmiron for Hunner's lesions, reality check. You can have a much better chance with a lesion therapy. IC subtype 2, bladder wall driven. These are the patients who absolutely have something going on with their bladder wall. They might have a chemical irritation of their bladder wall from chemical exposure like chemotherapy or drinking way too much diet soda or artificial sugar or some sort of chemical trauma. These are the patients who might have an infection of some type, a deep chronic infection that has been missed, or Lyme disease as an example. Or these are the patients who are menopausal and have hormone issues going on. And their bladder wall is not as normal as it should be. It's thinner. Okay. This is the subtype where Elmeron or a bladder coating makes sense. This is the subtype. Okay. IC subtype 3, pelvic floor driven. Okay. This is our biggest subtype. These are the patients who have frequency, urgency, pressure, pain, but it's not coming from their bladder. It's coming from their muscles. Okay. And who knew that tight muscles can cause the bladder to get messed up? But it does, because when you got tight pelvic floor muscles, you are reducing blood flow to the bladder, and it's really hard for the bladder to be healthy if, in fact, it's not getting good nutrition and good oxygen. Then you start having bladder symptoms. All right. Okay. And of course, for these patients, the tragedy is you have no idea you have a muscle injury. You've got urinary frequency, urgency, pressure, pain. You go to the doctor goes, hey, you must have infection. They give you antibiotics. They don't work. You go back to the doctor goes, oh, maybe you've got overactive bladder. They give you overactive bladder medications, or prostatitis. They give you prostate medications. Those don't work. And then they might say, hey, you got IC. Let's give you Elmeron. Let's give you other meds. Those don't work. You're not making any progress with that. And the reason why is because for many of you, it's not your bladder at all. It's your pelvic floor. How do we know your pelvic floor is driving it? Because when you go to pee, you can't start your urine stream right away. Because if you've got tight muscles, the tight muscles are squeezing your urethra and your rectum and your bowel and your bladder. It's pretty hard to relax, to empty yourself, to let urine out, to let stool out, if your muscles are super tight. So if you go to the bathroom and you're sitting for 5, 10, 15, 20, 30 seconds before you can relax enough to empty your bladder, that, my friends, is a sign of tight pelvic floor muscles. Also, if sex is painful, if driving in a car for a long period of time is painful, let's see, what are some of the other movement, things like that, anything involving muscles, that's going to point right to the pelvic floor. So again, there's no role in Elmeron for the treatment of pelvic floor dysfunction. How do you treat pelvic floor dysfunction? You get pelvic floor physical therapy. You do muscle work. The great news here, when Chris Payne developed this subtyping system, one of the things he made a very clear point on is we no longer really think of IC as an uncurable bladder disease. He thought that was very unfair to patients. If you're IC subtype 3, that's curable. Muscles respond beautifully to muscle work if you do the work. And so this is a really great subtype to have. This is one of my subtypes for sure. In fact, I was having pelvic floor spasms yesterday. IC subtype 4, pudendal neuralgia. So these are the patients not with a bladder wall injury, not with a muscle injury. These are patients with a nerve injury. How do we know? Because number one, their pain is neurological. It feels like you're being shocked, right? It's very sharp, very shrill. It's ow, what the hell was that? It's shooting down your leg, and it's like being shocked with electricity. But their symptoms are very movement driven. They're fine when they sleep, but when they sit on the side of their bed, it hurts. They're fine when they stand, but when they squat down or bend over, it hurts. That is a sign of a compressed pudendal nerve. And therapy for this is going to focus on relaxing muscles that are squeezing the nerves, as well as potentially calming nerves down. No role for Elmeron in this. Elmeron is not a treatment for this subtype. And then the last subtype is my dominant subtype. It's called central sensitization. This is the subtype that's inherited for many of us. IC goes back 3 generations in my family. My sister, my mother, my aunt, my cousin, my grandmother, all on my mother's side. All right. And so central sensitization means that we have a more sensitive nervous system throughout our whole body. We are known for very sensitive skin. Like I have to wear soft cotton. I cannot wear Polyester, I can't wear anything with the texture. It drives me crazy. I can't even tolerate seams under my arms. It just drives me crazy. We tend to be drug sensitive. We can't take a normal dose of a medication. We have to take smaller doses, pediatric doses, half doses, quarter doses. We tend to be food sensitive, where there are some foods that just don't work in our body, not just our bladder, but our body. For me, that's chocolate and oatmeal. If I eat those, I get bowel spasms for days. That's called a sensitivity. It's not an allergy, it's a sensitivity. We tend to have an amazing sense of smell. We can smell things that other people cannot smell, and smells really drive us absolutely crazy at times. Like we literally have to run from the room. It's very interesting that smells provoke pain, but they do. They do. It's fascinating. Now, I mean, it just gives me total context. When I came back from college and my parents had just refinished the windowsill in my bedroom with this, and like literally it was drying. It had been drying for maybe 24 hours. And they were so proud to show me what they had done in my bedroom. And I flipped my lid. I walked in and I was so overwhelmed by the smell. I like ran out and started crying and going, "What did you do? What did you do?" And they had used a wood, a wood product. It's not a solvent, a wood finish. Wood finishes are notoriously stinky. And I actually had to leave for 2 days. I was thinking about this the other day because I'm sure hurt them. I was really angry, but I didn't understand it. All I knew is it hurt. And I fled to my sister's house for a couple of days. Okay, now we know why. Is that I have central sensitization. My mother does too, but she was a smoker, so she kind of burned out her nose. I don't think her nose has the same level of sensitivity as mine does. So treatment for this is really going to focus on nerve calming treatments. Does Elmeron have a place in this? Maybe a little bit, because Elmeron has a bladder coating effect, and it can help maybe protect the bladder a tiny bit more, right? So if you're out there thinking Elmeron's the only act in town, the answer is you couldn't be farther from the truth. We have lots of treatments. We've got better treatments. We've got better directed treatments to really customize what's going on with you specifically, rather than giving you a one treatment fits all approach. So the question then is, if you can't take Elmeron or you don't want to take Elmeron, what do you take? Well, so what are the bladder coatings? You could do a heparin lidocaine installation, right? Where they put heparin and lidocaine in your bladder. And what that does is that coats your bladder, and it also has a numbing effect to nerves. So the most logical one is going to be a heparin lidocaine installation. But we also have supplements that are believed to have a bladder coating effect. And if you go back 3 months to May on our Facebook page, you will see a slide that I posted from the American Urology Association conference. I attended the class on urologic pelvic pain, the covered IC, taught by Robert Evans, Robert Moldwin, two of the top doctors in the country, and Jennifer Fariello Moldwin. They have a slide talking about supplements as mucosal barriers. So this would be something like Cystoprotect. You could try Cystoprotect. This contains chondroitin and hyaluronate. Chondroitin and hyaluronate, a natural constituents of the bladder wall anyway. It also has glucosamine, quercetin, and it's in an olive kernel oil base. This was invented by an IC researcher, Dr. Theo Herides at Tufts University about 15 years ago, as an alternative to Elmeron anyway. Thankfully, a lot of patients have already stopped Elmeron, not necessarily because they were having problems with it, but because they couldn't afford it. The costs of Elmeron have risen exponentially in the last 5 years. So many patients are now being forced to pay $1,500, $2,000 a prescription. And of course, who can afford that? I can't afford that. I could possibly afford that. And so one of the advantages of the supplements is that they're under $50. Another bladder coating is potential bladder coating is going to be Cysto Renew, which has some of the same ingredients. This one has chondroitin, as a bladder coating, quercetin, L-arginine, bromelain, and it has aloe vera in it for the soothing effect of the aloe. But the ingredient in here that I think is pretty compelling is lemon balm. Now, this is not citrus lemon. This is not a fruit. This is a mint with a lemony scent. And lemon balm is believed to help calm nerves down. And if we're dealing with kind of irritated nerves in the bladder, then that could potentially be a beneficial mechanism of action of this, Sister Reno. And of course, we have desert harvest aloe. Desert harvest aloe is the only supplement that has done a double-blind placebo-controlled study of their product with interstitial cystitis. And although it was a small study, it was a very, very valid study. It too has a multitude of potentially beneficial effects, including a bladder coating effect. All righty. So those are over-the-counter options that have a potentially a bladder coating effect. So those are also things that you could potentially explore. And again, many patients have already done that. So let me go ahead and go through some of your questions right now. So again, we're simulcasting on Facebook and YouTube. So if I'm looking down, I'm looking at YouTube. If I'm looking up, I'm looking at Facebook. So on YouTube, Wilka says, when I handle chemicals like hand sanitizers, even cleaning products, my bladder hurts and I get urethral pain and burning. Any suggestions? It's almost impossible for you to touch something and have immediate bladder pain. I don't know the mechanism of action that would support that. But if you are exposed to a chemical, it will eventually reach the bladder potentially. And do we have research that gives us a time? Gosh, you know what? That's a really good question. I don't know. All I know for me is one of the worst flares I ever had was when I drank, before I knew about the IC diet, I was at the movie theaters and drank a 7-Up from the fountain. And 30 minutes later, I was bawling my eyes out. The pain was so bad. So chemicals are if they're rubbed on your skin, they're going to enter your bloodstream. If your body doesn't know what to do with it, your body's going to try to eliminate it. Thus, it will end up eventually through your filter, through your kidneys, into your urine, where it is peed out. You know, when you take a vitamin, your urine turns bright yellow an hour later, right? Okay, why? Well, because your body can't use most of that vitamin. You're peeing it out. You pee it out. This is how our body gets rid of stuff. So Wilka, I completely support the concept of being exposed to a chemical and having bladder irritation. I just don't think I don't believe it can be immediate. Unless maybe you have an allergy or something like that. Rebecca says, can having a bladder wall damage sometimes result in pelvic floor dysfunction? Absolutely. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? The reality is that they're both involved to some degree because they're so closely connected. So if you have a spasming bladder, so remember, your pelvic floor is like this, right? And your bladder's right in the middle of it. So here's your bladder and here's your pelvic floor. So if your bladder's hurting and throbbing, your pelvic floor is going to get tight in a guarding reflex. That's what our body does to protect us from pain. Muscles in the area get tight. That's subconscious. You cannot control that. And so anytime you have bladder pain, your pelvic floor is probably going to get tight. If the bladder is triggering it, then how do we get the muscles to relax aside from basic muscle relaxation is we got to get the bladder to stop throbbing. So we calm the bladder. When we calm the bladder, then the pelvic floor muscles should release. However, consider the opposite circumstance. Consider patients whose symptoms begin after a muscle trauma. So here they've got a nice happy bladder, but their muscles get hurt and their muscles start squeezing, right? Their muscles start squeezing. So let's say you fell and hurt your tailbone. So here you've got muscles that are damaged and they're weak. And because they're weak, they cannot do the work they need to do, so they get tight. Like for me, I have a tight levator and tight piriformis muscle. So here you've got a normal bladder being compromised by tight muscles. What does the tight muscles do? It cuts down blood flow. Cuts down blood flow. And then it's pretty hard for the bladder to be healthy if it's not getting good blood flow. So then the bladder wall starts to break down. So for these patients, you could throw every bladder treatment in the book at them and they will never get better because their fundamental problem is, hello, super tight muscles. We got to relax those muscles, restore blood flow to get the bladder to heal. All right. Hello, Allison from New Zealand. Very, very nice to see you. Guys, if you would like a free IC awareness bracelet, and our diet card, just please send me an email to icnetwork@macmac.com. Laura on YouTube asked us to go over to pudendal neuralgia again. She read it's not considered IC. And the answer is it is considered a subtype of IC. Now, listen, for the last 15 years now, doctors have been exploring different types of IC. So in Europe, they have 16 potential types of IC. In America and Canada, or in Canada, they use the U-point system, 6 types of IC, or the input system, 5 types of IC. I use the pain system, 6 potential types of IC. The pain system is the only one that includes pudendal neuralgia. And the reason why, and I remember when U-point came out, I actually emailed the doctor who wrote it. And I said, why didn't you include pudendal neuralgia? I was really surprised they didn't. It's important to include because so many patients are misdiagnosed with IC when they actually might have pudendal neuralgia. And so it's a variant. Remember, we think of IC as a syndrome of multiple potential issues. And I work with pudendal neuralgia patients every day, and I also have a pudendal neuralgia. And to give you an example, let's see, let me draw a picture for you. Hold on a sec, and let me just draw this picture, and I think it'll make sense. All right. Let's see. Okay. Here's your spinal cord. I mean, here's your spine and your vertebrae, right? And you've got one nerve that branches off the spinal cord, breaks into 2 sections and goes down each leg, right? And so you're like thinking from this position that nerve is 2-dimensional. But in actuality, nerves are 3-dimensional sometimes. And so this pudendal nerve this is looking at the nerve from the side, right? So here you've got the nerve coming down and going down the leg, but there's a little tiny branch of the nerve that curves backwards. Curves backwards. And that's where my pudendal nerve entrapment is because my muscles are so tight. I've had 2 nerve blocks there. They managed to numb about a square inch, like an inch away from where they should numb. It's a tiny little spur of that nerve. So if I were to give you a question, so like here's the center. Nerve entrapments tend to be about an inch to the left or to the right of center, and that's really where mine is. Mine is kind of like right here. Another thing about a nerve entrapment is that there's always a triggering behavior which entraps a nerve. For me, it's sitting in this freaking chair right here. I've been sitting working on this for 25 years, and my body is rebelling. It wants me to be standing. I also have a yoga ball that I sit on that's very, very helpful. All right. Laura asks if I used Elmeron. No, I have never used Elmeron. It came out in 1996. I was diagnosed in 1993. I don't know. There's just something about it. I just didn't feel right. So I personally have never done Elmeron. Lynn says she emailed the link of the article to her urologist and that he hadn't heard about it, but told me it was all right if she wanted to stop the medication. He isn't sold on Elmeron anyway, with only 50% of his patients have success. Kim asks, can weather cause IC to be worse? Yeah, absolutely, because of stress. We know that if you're exposed to extreme heat or extreme cold, your body's going to react to that stress in multiple ways. And the bladder is one of the ways that stress can be manifested. But Kim, seriously, you say you've been in bed for days in horrible pain. I really, 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 truly hope you have done your due diligence and you're doing your flare management strategy. Literally, anytime you have severe pain, the very first thing you should do is please test your urine with a urine test strip. Let's make sure you don't have infection. IC patients do get infection. And then if you sign up for our free newsletter on our website, you can get our flare management guide. It's 40 pages and it has hour-by-hour rescue plans. But you got to do your due diligence here, Kim. We got to make sure, listen, to have severe pain for days, that's not right. We need to figure out why. Are you following the diet? Have you been exposed to anything? Are your muscles spasming? I mean, and actually the other first thing we need to do is we need to figure out, is it bladder wall pain or pelvic floor pain? Because we're going to treat them differently. Lynn said, did they publish it in the urology journal? That is where it should go also. No, it's published in the eye journal because they're eye researchers. Roxanne says she can't wait to talk to her eye doctor. Good. I really want you to. Tiffany says she's just like the 6 people in the study, right? Laura says she's been on Elmeron for 22 years. She just thought her vision was going bad because of age. Well, we don't know, hun. We don't know. And you don't know either. So rather than guess, go get the facts. Go have a doctor look at it. Melanie says, if we stop taking it, is aloe a better alternative? It's working for me, so I'm not, it's been working for me, so I'm not sure what to do. The supplements are really just try it and experiment. I personally believe that Sister Renew has more potential methods of action. And so most patients who kind of come through me, I usually suggest that they try this one first because it has the ingredients of the aloe and the ingredients of the Sister Protect. It's got the chondroitin. And so you're kind of getting a 2-for-1 or a 3-for-1 with something like this. Plus, I really like this company, Douglas Laboratories. I think they're super, super reliable. Carolyn says, I had brilliant eyesight until menopause. Yeah. Well, hey, hello, I'm wearing glasses. I didn't wear glasses a couple years ago. Tiffany, all they'd have to do is see if IC patients not on Elmeron have retinal pigmentation to prove. And that's what our research is trying to figure out, Tiffany. The survey is on our website. If you go to our blog, just go to ic-network.com and you'll see a blog on this issue. And at the bottom of the blog is the link to the survey, ic-network.com. Michael said the specialist in Nashville he went to 4 years ago said they do not recommend Elmeron to any patient. You wouldn't be the first. So Catherine's never taken Elmeron, was recently diagnosed with a serious retinal issue. So, Catherine, what they really want to do for you is see if it's hereditary, because retinal issues are often hereditary. Christine asks a really important question, and that is, how do we know that alternative treatments don't also have these problems, since not as big a group are taking any of the other treatments as Elmeron? You know, hon, I was thinking about that today. You know, kind of for me personally, and I think part of it is because I do have a degree in pharmacology, drug development, and I also have central sensitization. I have always approached any medication very, very carefully. I don't like taking new medicines. I don't, because I am the queen of side effects. And when I do take a medication, I always go for the lowest dose. You know, there's a pharmaceutical principle called highest effective dose and lowest effective dose. I might be saying that, I might be saying the highest one wrong. It's been 30 years since I got out of got my degree. But anyway, the concept of lowest effective dose is what is the least amount of medication you can take and still get a beneficial effect. And that's kind of my approach to any treatment. I want to take as little of anything as I can, because I know my body is so freaking sensitive. So when we work with patients who are trying anything, I always say, start slowly, like one capsule, one a day for a week. And then you can work up to 2 a day for a week and work up to 3 a day for a week. But a big part of that is listening to your body. If your body doesn't, if your body doesn't feel right, then that's important. I was reading on Medium this week, medium.com, which is a really good source of articles, a story of a young man who took finasteride, something like that. It was for baldness. He was going early balding at 19. Balding ran in his family. It was for hair restoration. And he very quickly became very depressed and had many other symptoms that are now associated with that specific medication. And he's really kicking himself that he felt the symptom early, but he kept taking it because he thought it would help. So there's a bit of intuition going on. I always like to say, you're the one living in your body. Nobody else can tell you when to pee. You need to tell you're the one who senses when you need to pee. You're the one who has an innate sense of correctness and intuition about what feels good, what versus what not feels good. So I don't know. I at least for me, I really listen, and I take tiny amounts. And I follow that same principle with supplements. I don't go for high doses of anything. So even though the last supplement I took was Sister Protect, and even though the manufacturers recommend doses 4 a day, I take 1. And I can feel 1. One works for me when I was taking it. I haven't taken it in about 2 years because my bladder's been pretty good. But Christine, I think you raise a really good, relevant point. And I would spend a little bit of time researching it. What I think is going to happen with this is, and I think the best case scenario for this is if we can get the FDA to issue guidelines that would require patients on Elmeron to have eye exams once a year, just to make sure that something like this isn't happening. And if you're taking Elmeron and you have no eye issues, then you're gold. But if you're taking Elmeron and you're starting to notice eye issues, that would be a sign that perhaps you've reached that point where it might be causing other issues. Lynn asks, what's the email to get the free IC awareness bracelet? icnetwork@mac.com. IC, N as in Nancy, E, T as in Tom, W is William, ORK @ M as in Mary, A as in Apple, C as in Charlie.com. All righty. Sarah says that Elmeron helps her and that she's found the news devastating. I agree. I was quite devastated by it too. and that you've been diagnosed with dry eye. Well, dry eye was not part of this. I've never taken Elmeron, and I also have very, very dry eye. I wake up 3-4 times a night and have to put eye drops in my eyes. So I have Sika, a variant of Sjogren's syndrome, which is notorious for dry eye, dry mouth. So that might be another kind of related condition. Thank you for rewriting that email, Allison. What is it? Lynn asked, what's the best way to find out which subtype you are? Watch the video on our website, and I think you can figure it out. I don't think you need a doctor to help you unless you have such strong, severe symptoms that you might have Hunter's lesions. Then you're going to need to have a doctor look in your bladder to see if you do. Roxanne says, I've been leaking now like mad, so I almost can't get to the bathroom. I had a hysterectomy, but they said I had IC. Girl, I had a hysterectomy last year, and I'm telling you, hysterectomy massively messes with your pelvic floor. I don't know when you had your hysterectomy, and I would love to talk to you. And if you could give me a phone call tomorrow, 1-800-928-7496, just do the patient support extension or the corporate office extension. Let's compare our hysterectomy experiences, because believe me, yeah, it caused massive, wicked pelvic floor issues for me, but they're slowly getting better, but it was pretty bad. Why do people with pelvic floor dysfunction have recurring UTIs? Well, actually, there's number one, if you've got tight pelvic floor muscles, that means you're not going to be able to empty out all the urine in your bladder, and that's a way that our body protects itself from infection, is it pees it out, right? So if you have urinary retention, that is indeed a risk factor for recurrent UTIs, that you allowing bacteria to be in your urine longer than they should be, that your bladder's not sloughing them out of your body as quickly as possible. Remember too that all bacteria are not bad. Urine is not sterile. You have good beneficial bacteria in your bladder too. I wanted to, hold on a sec. Here we go. But if you have recurring UTI, this is what you need to do. Next generation DNA urine testing. This is really the future of urine tests. What's exciting about this is, unlike in past years where they were doing broth cultures, where they were getting lots of really false positives and things like that, next generation DNA testing, urine testing, looks for DNA. It's going to find good bacteria, it's going to find bad bacteria, but even more importantly, it's going to find fungus, it's going to find candida. And we know from our own National Institutes of Health MAP Research Network, which is the big national IC research team, we know that many patients flaring actually have undiagnosed candida infections inside their bladder. And traditional urine testing does not find that. So you go over to bladderhealth.org, which is a new website that I built for this. I feel very, very strongly about this. I'm working with that company. I've been working with them for a good 9 months now. It's Microgen Diagnostics, really advocating for IC patients, advocating for an affordable test. And we now have an affordable test, $199 for testing that, if it were done the traditional way, would cost maybe $1,000. So, and you get results very, very quickly. So if you think you have a chronic UTI, or you keep being re-diagnosed with the UTI, have this done. The other thing that it's going to do is it's going to identify any drug resistance genes. Because seriously, if you've got the same bacteria, I always say to patients, you cannot just accept a doctor saying you have bladder infection. You have to ask what kind of infection. You got to start making notes, my friends. So is it E. coli? Is it staph? Is it strep? Is it actinomyces? Whatever. What is it? And you need to do that over time, because if it's E. coli in January, E. coli in February, E. coli in March, E. coli in April, E. coli in May, then what does that mean? That means you either have a super resistant E. coli that has not had proper antibiotic sensitivity testing done, or you have a source of E. coli in your daily life that is reinfecting you, like bath jets in a bathtub become well-known bacteria factories that will reinfect you over and over. However, if you have different infections, you got E. coli 1 month, actinomyces the next month, enterococcus, micrococcus, oh gosh, there's so many bacteria. I mean, if you're ureaplasma, mycoplasma, if you're all over the place, then what that tells us is that your immune system, that we got an issue with your immune system. Either your immune system is not very good fighting infection, or let me get my handy dandy guide here. Hold on a sec. The other reason why patients can get infection is if you don't have a lot of mucus in your bladder. So look, this is a bladder. This is an old Elmeron educational tool. So this is the bladder wall. So underneath the bladder, we've got blood vessels and nerves. Then we've got a whole layer of cells that we call the urothelium. And then we have a layer of mucus. Because think about it, how can the bladder hold waste for hours at a time and not get hurt? Because urine contains ammonia and urea and all sorts of damaging things, all the byproducts of the smoke you're exposed to and chemicals in your home and stuff like that. That all ends up in your urine. So how can your bladder hold toxins for hours at a time and not get hurt? And the answer is that your bladder is like your mouth. It is a hollow organ covered with mucus. So you can see that when you have an intact mucosal barrier, stuff in your urine cannot reach the cells, right? However, if you've got a damaged, thin, or missing mucosa, guess what? Irritants in urine get farther than they're supposed to, and so do bacteria. So it's a well-known fact that women who are menopausal because they've had hysterectomy or because they're older, myself included, because we don't have as much of this coating, because this coating is estrogen dependent. When you're young, you have lots of estrogen, you have a lot of coating. When you're older and you have less estrogen, you have less coating. So your bladder and your vagina and your vulva and your urethra are just going to be more vulnerable. In research studies with these women who do get recurring infections over and over again, 24 hours before it arrives in the bladder, they usually find it in the vagina. And that then, again, force researchers to ask the question, well, why is the vagina vulnerable to infection? What happened to vaginal defenses? And this applies. If you've got estrogen atrophy, you're probably missing some mucus. Thus, bacteria can get down in here and cause issues. That is why women who get recurring infections are often given a hormone cream, an estrogen cream, to use vaginally to help your body create a little bit more mucus so that you have natural defenses. Anne, oh my God, Anne on YouTube says she is one of the 6 in the Emory study. Oh, Anne, I want to give you a hug right now and just say thank you so much. Not only for facilitating that research at Emory, but being as wonderful as you are to have allowed that information to be shared. So the desert harvest aloe would be a reasonable option for you, my dear. So would the Cysto Protect or the Cysto Renew. But again, as somebody asked earlier, how do we know that other things can't cause retinal issues? We don't. And so using a less is more approach, I think, is valid. But you can't do that with antibiotics, because if you got infection, we got to kill that infection. But I hope I'm saying that right. I hope you understand what the point I'm trying to make here. There are quite a few patients who, whenever you have a flare, you self-medicate, man. You self-medicate with antibiotics. You self-medicate with anything you got. Or you call the doctor and say, hey, I think I have an infection. Can you give me antibiotics? And you don't get in and have that test. We've kind of been conditioned by the drug industry to turn to drugs for relief. And yet, again, when you look at the subtypes, the first thing we've got to ask is, well, is it a bladder wall flare or a pelvic floor flare? If it's a pelvic floor flare, we're not going to be doing too many medications. We're instead going to be focused on relaxing muscles. You're going to be stretching. You're going to be taking hot showers, hot baths, things like that to get muscles to relax. All righty. Anne, it's a privilege to talk with you. You're a hero. You're a hero in my book. You really are. Hi, Karen. Nice to see you. Okay, so guys, if you have questions, please go ahead and ask them in the right-hand side. Carol says 7-Up hits her right away. I have had one soda in 10 years, and it was only because I was really nauseous. I just don't need it. I value being thin. I don't like gaining weight. Marcia says, urologist told you nothing about the type of IC. Well, Marcia, listen, you can't hold that against your urologist because this is really only being done at the upper echelon. This is at the national and international level. I'm going to tell you right now that most local urologists don't have a freaking clue about the subtypes. That is why you walk in with the information and you give them the articles and you say, hey, this is kind of what we're looking at. Or you just say, listen, doc, I'm trying to figure out why I'm having this pain. I would like to know, is it from my bladder wall? Is it a Hunner's lesion? Or is it from my pelvic floor? Or is it from a nerve? You don't even have to mention the word subtype. At least you've got context. At least you now know the biological mechanism that drives the subtypes, right? And you said you don't have any pain, you have crazy frequency urgency. So frequency urgency is driven by the alpha afferent nerve in the bladder wall. So normally frequency urgency, we would see really first with daily consistent bladder wall irritation, like a multivitamin. Do you take a multivitamin? Are you having 1 cup of coffee a day, 1 green tea a day, 1 chai tea a day? Something like that on a daily basis that provokes that nerve over and over and over again could be at the root of that crazy frequency urgency. Steven says he's been doing RIMSO installation for 7 years, but Alberta, the Canadian Health Services up in Alberta, is saying that RIMSO and cystistat are no. I knew cystistat was not being manufactured. Are you saying that they're now not manufacturing RIMSO anymore? Holy moly. The name of that company that has it is Mylan. They're kind of notorious for stopping things. We've been trying to get more information on what happened with cystistat. You're the first to suggest that RIMSO was perhaps not going to be manufactured anymore. Should you consider it or stay off with these new findings? Stephen, the way you evaluate it is take a look at the AUA treatment guidelines, because what the American Urology Association says as you explore treatments is start with the easy, less risky therapies first. So here, I've got slides on that. Let me go through that real quick. Hold on. Let's see. They're slightly out of order. Give me a second here. Step 5, step 6. All right, here we go. Okay, so one of the issues that we've had for decades is that many doctors around the United States and around the world, frankly, have treated IC very, very differently. The language, the treatment offerings, educational materials, everything was so incredibly off the charts different that there was no consistency. So what you see is doctors in Europe, and then doctors in America, and then doctors in Canada and in Asia, they have all created guidelines for the diagnosis and treatment of IC in the last 10 years. And in fact, 2 years ago, the Canadian Urology Association issued their own treatment guidelines based upon a subtyping system. And if you come to our website and search for Canada, you should find the blog that I wrote on the Canadian Urology Association guidelines. But let me, as an example, I want to use the American Urology Association guidelines because, as an example. So the AUA convened a group of 30 IC specialists, and they created what they hoped would be uniform standards. And for treatment, they created a 6-step treatment protocol. And the steps are arranged with respect to the risk of adverse events. They don't want you to do step 6, which might be irreversible, before you do step 1. We want to do the easy, less risky stuff first. So let's go over this really quickly. So again, this is the American Urology Association 6-step treatment protocol for IC. It was originally published in 2011, and then it was revised in 2014. You can, and let me just do a shout out right now. You can go to their website and hold on. Hold on one sec. Wait. No, that won't work. Okay. So seriously, people, IC Awareness Month, one of the things that you could do that I think you all should do oh God, my writing is terrible. Hold on. Let's try this again. AUAnet.org. This is the American Urology Association guidelines. In the upper right-hand corner is a link. This is their main website. In the upper right-hand corner of this website is a link to guidelines. Click on that, go to the guidelines page, search for interstitial cystitis, and it will give you the guidelines. Print it out. Print 2 copies, 3 copies out. Okay, 1 for you, 1 for your primary care, 1 for your urologist, and maybe 1 for any emergency room you might have to go to. Okay. Of anything you could do for IC Awareness Month, to give a urologist for these guidelines will not only help you, it will help hundreds of other patients that they are seeing. Let's get them knowledgeable and informed about new standards of care. Okay. So, okay. So let's get back to these guidelines here. Step 1, water intake. Please, people. 6 to 8 glasses of water a day, my friends. Don't drink gallons. Don't drink 0. A lot of IC patients stop drinking water, myself included. I did too at first, because you start associating water with having to pee a lot. And frankly, you don't want to pee a lot, so you back off the water. The problem with that is when you back off with the water, your urine gets much more concentrated and much more irritating. Yeah, so the less water you drink, the worse you're going to feel. We need to keep your urine nice and dilute. So please drink your water. If your urine is dark yellow or brown, you're dehydrated. You got to drink more. If your urine is clear, you're drinking too much. 6 to 8 glasses a day, your urine should be a pale, clear yellow. All right. Number 2, the second step of step 1 is diet modification. If your bladder is vulnerable, can you please not pour acid on it? If your bladder is injured, doesn't matter if you're, again, this is really for IC subtypes 2 and subtype 5. But if you've got tight pelvic floor muscles, your bladder's compromised. Let's not provoke it further. So this means avoiding foods that are high in acid, avoiding foods that are high in caffeine, avoiding foods that are high alkaline. Seriously, I don't want you drinking alkaline water all day. That's just as bad as drinking acid water all day. We need you to be neutral. Like drink spring water. It's okay, drink spring water. So you can learn more about the diet from our website, or again, if you send me email to icnetwork@mac.com, I will send you for free our little diet cards. Alrighty? The American Urology Association puts supplements in step 1. Why? Because there are fewer adverse events than traditional medications. And the number one supplement that they talk about really is calcium glycerophosphate, also known as Preleaf. Preleaf is an acid reducer, right? And so Preleaf is a very popular supplement. It's not going to help the bladder wall, but it's going to at least protect the bladder wall from the superficial acid in your urine, or if the acid, protect the superficial tissue of your bladder from the acid in your urine. Step 1, muscle relaxation. Seriously, if you're tight, if you're stressed out, relax. You gotta go for a walk, do your relaxation. I always like to say God doesn't give us the skills to deal with IC and stress when we're born. We got to learn them. And lots of people have already done this. So let's learn from their successes. And muscle relaxation, body-wide relaxation works. It does. And acupuncture. Okay. Step number 2, physical therapy. Oral medications like Elmeron, hydroxyzine, which is an antihistamine, Elavil, amitriptyline, which is a low-dose antidepressant, bladder installations like rescue installations, heparin lidocaine installations, or Elmeron lidocaine installations. And of course, pain care. The American Urology Association is remarkably compassionate about pain. They want you to get your pain assessed at every appointment. They support the use of opiate medications if necessary, but they also want you to try to get to the source of the problem. Seriously, if you're in agonizing pain, we got to ask why. What biologically is provoking that pain? I will tell you that many patients that I work with have untreated Hunner's lesions. And if you treat the Hunner's lesion correctly, the pain goes away. So what the American Urology Association says is, yeah, let's treat the pain, but for goodness sake, let's use a multimodal approach and let's try to fix the problem so you don't need the pain medicine quite so much, right? Step 3 is a cystoscopy with hydrodistension and or the treatment of Hunner's lesions. Now, I will say one thing to say about cystoscopy with hydrodistension is 20 years ago, they used to do a high pressure, long duration therapy. In other words, they filled the bladder up massively and held it in there for a long period of time. And we now know that that's pretty damaging. The American Urology Association does not recommend high pressure, long duration. They want low pressure, short duration. I had one last year. It was a piece of cake. Compared to the old way of doing it. And of course, if you have Hunner's lesions, we want to treat the lesions. And generally, putting Hunner's lesion treatment in step 3, they have a caveat here that they say that, listen, as soon as you find Hunner's lesions, treat them. So if they find Hunner's lesions during your diagnostic evaluation, treat them then. You don't have to wait till step 3 to do it. As soon as you find lesions, we treat the lesions correctly with lesion-specific therapy. And what is that? Fulguration laser therapy, a triamcinolone injection, a steroid injection, or Lyris. Some people ask, well, isn't the IC research, what's going on with the IC research movement? Isn't it looking for the cure? Well, and I will tell you, the research movement is insanely good right now. We're having many, many incredible breakthroughs right now. One of the breakthroughs that we have is Lyris. First treatment in history to heal completely Hunner's lesions in just 2 weeks in some patients. Mind-boggling success, fantastic success here. So I'm telling you right now, the IC research movement is in fantastic shape. They're making great strides forward, and you should carry hope in your heart. Step 4, neuromodulation. That includes urgent PC or InterStim and Botox. Step 5, cyclosporin. I know we've got one patient in here who's currently on cyclosporin, and it's helped her. And step 6, of course, the last step, rarely do patients ever get to step 6, is surgery. And that's where if your bladder has gotten very, very small, they might expand it by doing an augmentation, or if your bladder's very, very diseased and damaged. And we see that in patients who just have never received correct treatment, or they haven't been treated properly, or they got profound damage. Worked with one patient who, she was young. She'd had bladder symptoms for about a decade, and she was a wreck. She was in terrible, terrible shape. And when they finally went in and looked at her bladder, what they found was that it was ruptured from a car accident years earlier. And here she'd had urine leaking into her belly for a decade. It's no wonder she was in agony. And of course, in that case, they could not save her bladder. They did have to remove her bladder. Okay, so getting back to your question, what's the option here? What the AUA says is they put supplements ahead of oral medications. All right, I am still taking, and guys, if I pass by your question, just know that my screen feeds them really, really quickly. Let me see if I can expand this, especially on Facebook. We've got almost 100 questions here, or comments. Roxanne asks, can you get the urine test strips at the store? Yes, you can, but you can also get it from the IC Network store. We have a wonderful mail order center on our website, which is what supports all this work. Come on over to icnsales.com and you can buy all the books, chair cushions, heating pads, and we have the supplements and we have urine test strips there. All right. And that's what helps make these meetings happen. Also, guys, we have a magazine, the IC Optimist, that all of our members get. And so you can also become a member of the IC Network. This is our 15-year anniversary for our magazine. And this is our summer issue right here. You can get it for as little as $25 a year. So come on and sign up for our magazine also. Getting back to the AUA guidelines. What do they no longer recommend? They do not recommend long-term antibiotics. They do not recommend BCG or RTX. They do not recommend silver-nitrate or chlorpactin. They do not recommend high-pressure hydrodistensions, and they do not recommend long-term steroid use. Rita asks, does anybody here have acid reflux with IC? Rita, that brings up a really good question. I will tell you that I have had gastritis off and on for many, many years before I was finally diagnosed with gastroparesis about 5 years ago. We did a survey of IC patients about 5 or 7 years ago where we asked about the onset of, not the onset, if we wanted to know if patients had stomach issues. And I'll tell you, 95% of the patients that we talked with did. And acid reflux was very common in them, along with gastritis, gastroparesis. I think I have an article on that in our magazine from a couple years ago. Annie says, does anybody have problems with antibiotics? Annie, I will definitely share that there are some antibiotics out there that are very bladder irritating. A good example of one is Augmentin. You generally know within the first couple pills if it's going to kill your bladder, and that's when you call the doctor and say, hey, this is killing me, I need a different one. That happened to me with the sinus infection several years ago, and I was switched over to another one and had no problem with it at all. Kelly, I don't have any correlation about IC and diabetes. I don't believe that there's a connection between the two. Sharon says, I remember going back years, I believe there was a recommendation to have a slit lamp eye exam regularly when taking Elmeron. Actually, Sharon, that was DMSO. That was RIMSO. RIMSO was the one that recommended having the slit lamp eye examination. That was not Elmeron. I don't believe I've ever seen any eye recommendations with Elmeron. However, that was very common with RIMSO. Rita asks, why does antibiotic not work with IC? Because Rita, IC is not infection for most patients. IC is injury, it's trauma. And again, going back to the subtypes, if you have Hunter's lesions, you could have a virus, which would not respond to an antibiotic. It might need an antiviral, or you might have something else going on with a nerve that would cause that lesion. IC subtype 2, Yes, you could have a bacterial infection, but you might also have menopause. You might have a thinning mucosal barrier of your bladder, or you just might have acid-induced injury. And if you have acid-induced injury because you've been a soda junkie or a coffee junkie, antibiotics would not help that. What would help that would be getting rid of the acid that you're drinking every day. I mean, guys, listen, realize our bodies have been designed for tens of thousands of years. And when you think about evolution, it takes 5,000 years for an evolutionary adaptation to occur. And so our bodies and our bladders were designed for life 5,000 years ago. Well, what can we say about life 5,000 years ago for many of us is there was very little acid. I come from Norway and Sweden. We had no citrus. The only acid we were exposed to were unripe berries. And so when you think about the acid load in today's daily life, whether it is the soda, remember when we were younger, our little orange juice, our orange juice glasses were tiny. I mean, it was half the size of this, right? And now when people get orange juice, they get a giant thing of orange juice. And so whether it's soda or whether it's orange juice or something else that you're eating, our bladders are not necessarily designed for high levels of acid like that. And it's going to take a toll over time. So reducing that acid load, I think, is important. Tiffany says she'll be able to tell if her eye problems are associated with the Elmeron because she's stopping the medication. And if that means that your retina stabilize or get better, then we're going to be able to say that that's the Elmeron. But if your retinas continue to get worse, then we can maybe say that it's not the Elmeron. That's why we need more research. The phone number 1-800-928-7496 is at the top of our website. Just go to our website. It's at the very top of every page. Anna, to get the free, you guys, if you want the free IC Awareness bracelet, send your name and snail mail address to icnetwork at mac.com. icnetwork@mac.com. So Blanca says her son's bladder is very raw and bloody, according to the urologist. And this week he was prescribed Elmeron for IC. His son doesn't recall any injury, has never used drugs, got a very bad UTI and got diagnosed after infection cleared up, and urgency did not. So again, Blanca, in your case, honestly, I would really have to wonder if there is another secondary infection going on, or resistant infection going on that has not been treated correctly. And I think that out of an abundance of caution, it would be very interesting to have his urine tested with next generation DNA urine testing. In 25 states, you can order it yourself. You don't need to have a doctor's signature. It's $199, which is a deal for testing of this type. But what it's going to do is it's going to identify any drug resistance genes, and it would be very interesting to see if it can find any residual bacteria which could still be contributing to that raw bladder. The fact that he got a very bad UTI and was diagnosed after that makes me wonder if part of that UTI or a different UTI might still be present, causing his symptoms. And in terms of finding doctors in Houston, it's really going to be Baylor. And the doctor that I'm familiar with there is Dr. Chris Smith. I don't know him personally. I think I've talked to him once in 20 years, but he's kind of the go-to doctor in Houston. But many patients who have kids with IC actually travel instead to go see Dr. Robert Evans at Wake Forest University in North Carolina. He is, in my opinion, the national specialist for children with IC and teens with IC. And we've got families and parents who bring their kids from across the country over to Wake Forest to be seen. And so I think it'd be very interesting to do the next generation testing, because you can literally do that tonight if you wanted to, and then see what those results are. And if those results are inconclusive, and his bladder continues to be very raw and bloody, then going and seeing somebody like Robert Evans is reasonable. I mean, I want you to really, I need you to focus on anatomy here. His bladder is bleeding, right? It's bleeding. So we need to know why. There are going to be some doctors going to say, you know, let's just try medication here and there. I come from a different approach. Man, I want to know why it's bleeding. I want to know what's bleeding. Like for me last year, I was bleeding from my vagina, and it turned out to be uterine cancer, right? And so I don't like guessing when it's something serious. I want the facts. And so before I even talk about treatment, I usually say, I want eyeballs on the organ. I want you to look at it and tell me what the hell is bleeding. But that's my approach. That's what I do. I don't, we guessed for 6-7 months with my cancer before we found it. I was very foolish. If I had just let him look, he would have seen it, but I didn't. So I think it's important to focus on anatomy first. And he's bleeding. That's important. We need to figure out why. I will tell you that untreated infection will cause the bladder to bleed. And that's why, again, something like this is reasonable. And most infectious disease doctors would do this anyway. So let's, you know, a typical urine test is not going to find as much as this will. A typical urine test will only grow out 1% of the bacteria. This will grow out 99% more bacteria. So this is a more valid way of testing your urine. Rita says, you use Vagifem and still have infection. So Rita, again, I would want to know the type of infection. Is it the same infection over and over and over? If it is, my dear, then you might have a drug-resistant form of that infection. And so again, you are the perfect candidate for this. That is exactly when this is applied. So when people have recurring infections that keep coming back, that's when we take that testing to the next level and do this testing instead. John, is there an effective natural muscle relaxant? I don't know. Hold on. So for people who have pelvic floor dysfunction, we've got 3 wonderful books. We've got the IC Solution, which is the first book that really talks about the bladder muscle connection. Let's see if she has anything in here about this. Nope. You know, I mean, really, the natural approach to muscle tension is going to be muscle relaxation, taking a long hot shower, taking a walk, getting back in touch with those muscles, trying to figure out what's making them tight in the first place. And then with respect to trying to reduce that muscle tension, you have to do the hands-on work. You know, you can't just, guys, you can't fake it. When you got a pelvic floor, remember, your pelvic floor is like this, right? You've got muscles that go from left to right. You've got muscles that go from front to back. You got muscles that go from low to high. It takes a physical therapist to tell you which muscle is the problem. So for me, it's a muscle that goes this way. It's my piriformis muscle. And so you have to go to a physical therapist at least once to have a proper diagnostic workup so that they can tell you which muscle is the problem. And then you've got to make a commitment to doing the muscle work. And some of us are passive aggressive, myself included. I should do it every day. I don't. I did it yesterday. I haven't done it today. And there are also some tools that can be very helpful. And an example of a tool is this. This is, I use this on occasion when my pelvic floor muscles are freaking out, as they are wont to do since my hysterectomy. This will allow you to very easily insert into your vagina or rectum and just very gently. I mean, this is all about lengthening muscles. You know, you're not pushing like this. You're smoothing. We're trying to stretch that muscle out. We're trying to release that muscle tension. And so there's a lot of long, slow movements on those muscles. Give you an idea of how muscle fibers work. You've got long horizontal fibers that go the length of the muscle. So normally a relaxed muscle is like this. The fibers are just kind of touching. When a muscle gets tight to work, they slide like this, right? And then they lock into place to help you lift something, right? To pop, you know, when you pop a bicep, you get a lump here. You know, the muscle pops out. That's because the muscle fibers are like this. Sometimes, though, they get stuck there. We call that a muscle knot. And so you do physical therapy to release them. And how do they do that? They rub the length of it. You know how if you have a muscle knot in your back, you have somebody push on it? Because when you push on it, sometimes it will release it, or you rub it the length. Okay, I'm looking at YouTube here for a moment. Missy Yenna says, I'm in the UK, finding it hard to get my urogynecologist to appreciate that you may have IC and not overactive bladder, even when I print out any articles, any advice. Yeah, hon, the difference between, well, actually, in our summer magazine, we summarize all the research that was presented on IC at the big annual meeting 3 months ago. And interestingly, there was an article, there was a research study. Now, if you can see this, overactive bladder and interstitial cystitis may be a continuum. So these researchers believe that, and remember, overactive bladder never existed 20 years ago. Overactive bladder was a term created by the company that made ditropan. You know the old TV articles, the TV commercials, gotta go right now. Well, they didn't want to say incontinence on TV, so they came up with a media-friendly term called overactive bladder. And then they paid a couple of big, powerful doctors to try to normalize the term overactive bladder. And overactive bladder is defined as somebody with incontinence or somebody with frequency urgency. And I remember at the time I emailed Dr. Lowell Parsons and said, so isn't this going to make a diagnosis of IC much harder? And he goes, yeah, it is going to make it harder. So now we have researchers who believe that they're just a continuum, that overactive bladder is perhaps a very mild form. People with frequency urgency in overactive bladder are just a very mild form of what later can be diagnosed with IC. But again, we have to think about the subtypes. I bet there are subtypes in overactive bladder too. In fact, I'm sure of it. I just don't think I haven't read an article on it, but I'm sure somebody's thinking about it. So anyway, getting back to that question, the big differentiator, Missy, is pain. If you have pain as your bladder fills with urine that is relieved by urination, then you have IC. If there's only frequency urgency, then Some doctors would describe that as mild IC or IC subtype 2, and some doctors would describe that as mild overactive bladder. And in Europe, you would be diagnosed with IC type 1A in their typing system, in the Essex typing system, rather than 3C, which is Hunner's lesions. So, alrighty, let's see here. I hope you guys are having a good Sunday. I hope you've had a good weekend. And I hope nobody's been affected by the hurricane. Penny has been taking magnesium. Interesting. I take magnesium too for just to try to keep my bowels a little bit happier, and also for muscle spasms. Taryn, I had a hydrodistension 3 weeks ago, and I've been using Rapaflow, Elmeron, Aloe, and Prely for the past week. I have severe right lower quadrant pain. Urologist keeps telling me it's my bladder flaring and to add Urabel. Not sure who to go to see what is going on. So, Taryn, the reality is anytime you have a test like a hydrodistension, you are potentially introducing bacteria into your bladder. It is very well known that many patients having a hydrodistension experience a post-op infection. So the fact that you're having severe pain after a hydrodistension absolutely justifies having urine testing to make sure you did not pick up a post-op nosocomial infection. Nosocomial means acquired in a medical setting, acquired from a hospital. These are the infections that are the result of cross-contamination of hospital instruments and all that sort of stuff. Nosocomial infection is really a terrible problem. And also too, I mean, I really have to say that bladder wall pain is usually centric. It's not to the left or to the right of center. If your pain is to the right of center, I would be looking at your appendix. I would also be looking at your pelvic floor, because the other reality too is that because you had a hydrodistension and your bladder has been kind of screaming from that hydrodistension, your pelvic floor muscles have gotten tighter. You cannot turn that off. That is called the guarding reflex. And so I wonder if perhaps you have a muscle knot, a tight, painful muscle knot on the right-hand side. So you're not sure who to go to. You don't say what state you're in. I mean, you can ask for a urine test from your primary care. You can ask for a urine test from the doctor who did it, or you might be able to order this on your own. If you go to bladderhealth.org, it'll tell you the states where you can order it by yourself. That would be a very, very important piece of this puzzle to try to figure it out. And I think I would also want a pelvic floor assessment. Let's make sure your muscles are not involved. And again, using the American Urology Association treatment guidelines, they don't tell you to start with oral medications first. They try to start you with supplements. And so you're doing the Aloe, but maybe you could also try something like Cysto Protect instead of the Elmeron, or Cysto Renew instead of the Elmeron, and see if those have the potential of helping, because they don't come with the side effects that Elmeron comes with, may come with. Christine said, someone earlier referred to a correlation of IC and IBS. I believe I'm IC subtype 2 and Elmeron changed your life. So if I found I did need to stop the Elmeron, do any of these alternative treatments help mild IBS? Well, Elmeron would not help IBS. Directly, the bowel kills Pitocin. When you take Elmeron, 92 to 93% of it is rendered inactive in the bowel. Only 8%, 7 to 8% of it actually arrives in the bladder. So I'm not aware of any research that has shown that Elmeron has any sort of beneficial effect anywhere in the gut. However, if the Elmeron has calmed your bladder down, then your bowel would have also potentially calm down. We know it's called the pepperoni pizza algorithm. We know that when the bowel gets super irritated, the bladder becomes irritated. When the bladder gets super irritated, the bowel can become irritated. In patients with IC subtype 5, I'm one of those patients. And why? Because the nerves are connected, and they do kind of tracer studies from the bladder, from the bowel. And what they find is the tracers line up at the spinal cord. So we know that those nerves eventually blend together as they reach the spinal cord. So the theory here is that the neuroinflammation is spreading from one nerve to the other. So what they say in IC subtype 5 is, let's fight all the pain generators. Let's work on the bowel and work on the bladder, get both to calm down so they both don't become so irritated. So again, I don't see Elmeron helping your bowel directly in any way, shape, or form, but it can certainly calm your bladder to the point that might also calm your bowel to a certain degree. But frankly, any coating would do that, because you have to remember it's a coating. It's a chemical Band-Aid, right? So this is an Elmeron educational postcard here, right? And so when you put that coating in, you're just protecting this tissue so that urine can't go in there. Other coatings have the potential of doing the same thing, following the same principle, for lack of a better term. Lynn, my urologist says he likes Urbil and it helps many patients. Is that typically for a bladder wall subtype? Yes. Tiffany points out that with this maculopathy, the Elmeron maculopathy connection, there's actually a pigment that is changing the retinal cells and impairing vision. It's a substance. And again, the Emory eye researchers, their theory is it might be a toxic metabolite of the Elmeron. Lark, thank you for sharing information on the valerian. I don't have any experience with that at all, guys, so I can't vouch for it. I just don't know. April says she's got a raw labia and urethral burning. You've been told it's not yeast. Nothing has helped. So my dear, again, something like this would prove conclusively if it's yeast, because it could find it in your urine. But the odds are it's probably menopausal or the loss of estrogen, because when you lose estrogen, you lose mucus, and you lose that mucus on your vulva, in your vagina, in your urethra, and in your bladder. And so this dryness, we call it estrogen atrophy, is common. And the first part that it usually hits is the urethra. Happened to me when I was 51. It felt like I had a drop of urine stuck in my urethra that just would not come out. And my urethra became very irritated. And I'm telling you, I mean, listen, my IC self-help skills are really good, right? I mean, because I've been doing this a long time. I threw everything I knew at this urethral irritation and nothing worked. And when I finally went to my urologist, put me up in the stirrups, he took one look and he sighed loudly. He goes, "Jill." And I'm like, what'd I do? Imagine I'm laying on my back with my knees spread. He's looking down there. And he goes, didn't you use the estrogen cream I prescribed for you a year ago? And I went, no. And he goes, why? And I said, because I didn't think I needed it yet. And he's like, well, I prescribed it for you because I thought you needed it. And my answer was, but I'm not that old. In my brain, I'm 25. I'm not over 50. It is so weird to be over 50. It never dawned on me that I was at that age where estrogen was starting to influence my urinary function and my urethra. So they re-prescribed it. He had me put a pea-sized drop at the end of my finger, rub it at the entrance to my urethra. And within a week, that symptom went away. And I do that today. And if I forget to do it for 10 days, that symptom comes back. So the urethra is one of the first areas to really respond negatively to the loss of estrogen and show estrogen atrophy. Kathy, if your urologist won't do it, I bet your primary care will do it. I mean, you can order, basically what you do is you order the test, and it'll come with a sheet you fill out, and you just take that to your doctor and get a prescription for it. I mean, get a signature for it, not a prescription. Just have them sign it. I don't know a doctor who would say no, especially if you're paying for it. It's good information. It just means that you might be challenging them because they don't know about it and they have no experience with it. And that might be difficult for them. They might feel awkward saying, I don't know. And what you get to say back is, well, we don't know either. But what we do know is I'm getting these infections over and over again. And that current testing, the testing we've been doing has not been that helpful in figuring this out. But this DNA next generation test could give us more information. So I would like to do it because I would like to get better. And generally, most doctors would say yes. Aaron, can pelvic floor fires cause your bladder to burn like fire? Yes. Yeah. Because a muscle that's working hard is a muscle that's building up lactic acid. Lactic acid burns. You know, if you're going to go run around the block, your leg muscles would start burning after a while because you're working them hard. A muscle that's working hard burns. You know, interestingly, the bladder itself usually does not cause a burning sensation. The bladder itself, if her bladder wall damage, is more of a sharp razor blade or ground glass. There's a sharpness to it rather than a burning to it. We associate burning more with muscles, or the exception to that would be something that I call urine burn, where if you pee, your urine feels super hot when it crosses your vulva. And your urine is not hot. It just is a reflection of dry skin on your vulva. If your vulva is very dry or your vulva is very sensitive, you're going to have urine burn on that. Laura asks, is marshmallow root good for a bladder coating? Not in my opinion. Marshmallow root can be somewhat soothing. It was a fad about 15 years ago. The problem with marshmallow root, believe it or not, is some people actually flare from it. So I am not a fan of marshmallow root to any great degree. I know that it swept through the online IC community before Facebook. I mean, this was back in the old internet news groups, and there were people out there saying it was secure for everyone. And yet I was getting the phone calls from the patients who were saying, oh my God, my bladder's screaming, I tried marshmallow root. You know, so I'm very cautious with marshmallow root. We do sell it on the IC network. It does help some people, but you know, I'm not a total fan of it. So Tabitha, again, you had IC diagnosed 10 years ago through cystoscopy, never had UTIs until last year. Super helps, but it also comes back. Now listen, there's something you've got to understand about Cipro. Cipro is now very, very well known for some very, very severe side effects, so much to the point that 2 years ago, the FDA did a very massive warning about Cipro and say that it should not be used for bladder infections unless nothing else will work. Why? Because it can cause tendon damage. It can cause aortic aneurysm. There are lots of very, very severe potential risks taking Cipro. So if you have a doctor that's prescribing Cipro kind of commonly for every infection, the Food and Drug Administration says that's a mistake. They don't want that to be done. And so I want you to Google Cipro FDA warning so that you can go find those documents about Cipro. And instead, again, since you're having positive UTI over and over again, this is when you do next generation DNA testing. It will do a much better job of identifying what pathogen you have, but more importantly, it will identify any drug resistance genes found. So go over to bladderhealth.org, watch the videos of urologists, and it'll give you the list of states that you can order it in by yourself or if you need a doctor's. But that's what I would be doing next. This is, I think, the missing piece. And, there are some people out there saying, Jill, took you long enough. Well, I've never been against urine testing, but we were waiting for super reliable urine testing because there's lots of urine testing that's not necessarily reliable. But this is what the MAP Research Network uses. This is what the National Institutes of Health uses in their IC studies, next generation DNA urine testing. And so this is the future for urine testing for IC, in my opinion. And, it's interesting. I was going over because I'm writing a chapter, the first chapter for a new book on IC. And I was going over all the old treatment guidelines, and I went back to the European guidelines for IC with their 16 subtypes. And nowhere in those subtypes is pelvic floor or pudendal neuralgia. I mean, they're really focusing on the bladder. And I was like, I always thought that was a flaw of their protocol. But then I took another look at their protocol, and their protocol demands extensive urine testing, especially for ureaplasma and mycoplasma. So in Europe, before a diagnosis is made, they do really deep urine testing, much more aggressive than the United States does. Aaron says, that would explain why the more physical I am, the more it burns. Or the electricity. And, hon, the electricity is a nerve. Anytime movement triggers symptoms and discomfort, that points to your muscles. Now, what I want you to do is I want you to pay attention to which movement causes the nerve pain. Anytime you have the electricity or a sense of vibration, start focusing on identifying what movement triggers that. And that will help us understand if you have an entrapment or not. Like me right now, sitting here, I've been sitting here for 2 hours. I've got the little flicker going on in my left butt cheek. It's a little tiny. And if I stay here too long, it's going to get bigger. And if I were to stay here for another hour or two, it would be like this. And then I would be in pain. So you really got to listen to those symptoms. I will be standing up sooner rather than later. All right, last call for questions. It's been 2 hours and 10 minutes. Mary Jo. Anne as asking if I'm sharing the survey results with Emory. Absolutely. They've already gone through my survey. They're creating their own IRB-approved survey that we will be promoting. And I've already given them open access to all of the data for our study. I've already talked with them in depth about it because we want to figure this out. I really felt it was my duty and our duty to make sure that everything about this was explored thoroughly, because again, thousands of IC patients have taken Elmeron, and if this is a real, and I do think it is real, we need to go to the FDA and make sure that they tell people that they should have eye exams. Mary Jo says, my uro wants me to use estrogen. My doctor does not because I have a blood clot. It's hard to know what to do. Well, just Mary Jo, differentiate between oh, and Anne's going to see Dr. Jane next month. Awesome. That's really good that you're going to go see him. Mary Jo, you have to differentiate between oral estrogen versus estrogen that's cream that's put on your skin. If it's oral estrogen, it's going to be distributed throughout your entire body, through all of your blood vessels. And we can see that that certainly would potentially compromise blood clots. Estrogen that's applied topically is not going to have quite the same absorption into the bloodstream. So many believe that there's less risk than that. But the fact that you have an active blood clot is deeply concerning. So absolutely, you definitely need to listen to your doctor and your doctor's advice. But I would just ask them what the risks are compared to oral versus topical. Okay. Well, I think ultimately you've got to listen. Your life is at stake. Blood clots are dangerous. If your doctor thinks that there's a risk, then I certainly wouldn't do it. Your safety comes first. So instead, what would you do? You need something that has a bladder coating, a moisturizing, soothing effect down there. We have something called Medicine Mama's V Magic. And I have a thingy of it, but hold on a sec. I can't get it right now. So Medicine Mama's V Magic is an olive oil. It's an organic olive, avocado, sea buckthorn oil. I use it myself. See, I'm squirming on my chair right now. Sorry about that. I use it myself for dryness down there. And so you might find using that, it's kind of the consistency of Vaseline, but slipperier and not as sticky. And I love it. And it doesn't irritate at all. And there's no estrogen in it at all. So Medicine Mama's V Magic, you can find that on our website. Some people also use Luvina, which is a moisturizing product. And that might be helpful too. But honestly, the Medicine Mama's V Magic is awesome. And so I think I would look for something like that instead. And when somebody leaves that room, I can go get the sample for you. Aaron asked, will this be available? Yes, the recording would be available for at least a week. I haven't deleted. I've only deleted one recording so far. I think we have about 10 recordings. Laurel says, some topical products contain propylene glycol. It burns my tissues and make me flare. You got it, girl. Me too. Me too. And that's why the estrogen cream that I use is not a branded estrase or Premarin, which many are filled with propylene glycol, which is very, very irritating. The Medicine Mama's V Magic does not have any propylene glycol, and I get my compounded estrogen cream from the Women's International Pharmacy, and it too does not have any propylene glycol. It is specifically propylene glycol free. All right. If there's one thing I want you to remember, and I'm looking at you, hopefully, if there's one thing I want you to remember from this conversation is you've done nothing wrong. This is not your fault. There is no shame. There is no blame. I don't want you to carry any guilt. I don't want you to start feeling like you're damaged goods. I don't want you to feel like you're a bad person. I don't want you to feel like you're not a good wife, not a good mother, not a good friend, not a good sister, not a good brother. Listen, you're hurt. You're hurt. You deserve the same love and care that anybody in your family would get if they were hurt. You know, you would run to their side if they were in the hospital in an accident. You, my friend, are worth exactly the same love and care. So please don't beat yourself up. Please don't beat yourself up like I did when it first started for me. If you need help, you need to ask for it. You are entitled to their love and care. But, you know, we IC patients, sometimes we hide it. We don't want anybody to know. And we have also had some doctors who've told patients, don't tell anybody in your family you're in pain, which I think is a terrible injustice. If you need help, ask for it. But ultimately, it comes down to you and me. It's about what do we need to do to get our bodies and to get our heart and to get our soul into a better place. And it's not taking about a big giant step. I don't need you to go run a marathon. I want you to do little tiny things every day to make yourself better. So every day, number one, do something for your spirit and your soul, whatever that is. It might be going and walking among redwood trees. It might be going to church. It might be listening to Joel Osteen like I do a couple of times a week. Do something that comforts and nurtures your soul. It doesn't have to be religious, just something that gives you peace, my friends, something that gives you peace. Every day, I want you to do something for your bladder, whether it's following the IC diet or, your body and your pain, going out and taking a walk, taking a warm bath. Reward yourself. You're working hard. You have never worked as hard as you are working right now in pain with IC. You deserve a reward, but it has to be a responsible reward. I don't want you to go start drinking coffee or having a soda, but go make cookies. You can go make cookies. You can go, just don't make chocolate chip cookies. Make carob chip cookies or make oatmeal cookies, something like that. But do something nice for yourself every day, especially if you go to the doctor, especially if you've got to go have a test. Read a romance novel. Call a friend. Call an old friend. Talk on the phone with somebody. Light candles, whatever. I mean, unscented candles, not scented candles. And then I need you to do something every day to build your knowledge level. Okay, because you're not going to be able to go in and go toe to toe with your doctor unless your knowledge level is up there. And it's shocking to me the number of patients who are still focusing on what we knew 20 years ago rather than what we knew today. So I want you every single day to come to our website and read one blog. Could you just read one blog? Come on, we're rated #1 in the world by Harvard Medical School. I work hard. I curate all that information. I've got really good information about IC. I've got a really good blog, very popular, 7 Causes of Urethral Irritation. So one blog a day. Let's just build that knowledge level up. And of course, please come subscribe to the IC Network and get our magazine. The articles in our magazine often do not appear on our website for at least 6 months. And so if you want the latest cutting edge information, this is where you're going to get it. So come subscribe to our magazine too. All righty. As always, I'm available for coaching. If you would like some one-on-one time, you are welcome to call me. It's not a problem. I love working with patients. I spend all day working with patients on the phone, which is why I get a little slow on other things. 1-800-928-7496. We have a free phone support line. If you've got a couple questions and you want to talk 10, 15 minutes about what's going on, it's free. It's fine. Call. I would be happy to talk with you. I also have other staff who answer the phone, but usually it's me. And then if you want to spend more time and go in depth into what's going on with your history, you can sign up for wellness coaching. We have wellness coaching through our website also, okay? And that I just did one at midnight the other night for somebody in New Zealand. It was wonderful. So literally, I stay up all night. If you're in another country and you're available when it's 2 a.m. for me, believe me, I'm going to make that happen because I know what it's like to be alone and suffering in silence. All right, my friends? You're a good person. Always remember that. Be proud of yourself when you look in the mirror at the end of the night, because you're working very hard. Don't worry about what other people say. It's about how you feel about what you're doing. I need you to be active. I need you to be proactive. I need you to be strong. I need you to be courageous. You can do this, and we are going to do this together. Let's kick some icy butt together, all right? Okay, I'm going to sign off. See you later. Oh, and like this Facebook channel too, and our YouTube channel. Okay, bye-bye. Goodbye, YouTube. I see you. Hey, listen, we still got 12 people on YouTube. The Facebook channel is cut down. Anybody got any last questions on YouTube? Catalina, do you know about anyone doing research on the microbiome on IC? Girl, oh, yes. Yes, yes, yes. The microbiome research in the bladder is stunning. Absolutely stunning right now. And I've got something really exciting that we're working on that could be a total game changer about the biome. And I've signed a confidentiality agreement, and I can't tell you more. All I'm going to tell you, I made a prediction in this magazine, in my editorial. I do believe it was this one. It might have been the last one. Could good bacteria hold the key to our bladder health? And the answer is, oops. Yes. I truly believe in the future that we're going to be treating bacterial infection with beneficial bacteria. And I've already had several companies approach me about creating custom formulas for the bladder. I can tell you right now that a couple of companies are trying to do it. And we've got something even more compelling and interesting coming down the pipeline. And that's just Very, very exciting. And I think if anything, we're really learning that the overuse of antibiotics, the guy who won the Nobel Prize for inventing antibiotics years and years ago in the 1940s, in his Nobel Prize winning speech, he predicted antibiotic resistance. He predicted that we would be causing great damage to the body if antibiotics were overused. And his prediction was right. If you look at India, for example, in India, antibiotics are over the counter. And India has some of the highest antibiotic resistance rates in the world, and not just simple antibiotic resistant, life-threatening antibiotic resistance. We've had patients in the United States who have gone to India and they've fallen and they've gotten a scratch or they've broken their leg and they've come back septic with body-wide untreatable infection because the antibiotic resistance is so bad. So you're definitely going to see in the future an emphasis on finding non-antibiotic approach to treating infections. And I think that future is going to be correcting the microbiome, the urinary microbiome. And that's as close as I can say. That's as close as I can say to this. All right. All right, my friends. Very nice to see you over on YouTube. Make sure you like this channel. And if you have any questions, you know who to call. All right. Okay. I'll talk to you later. I need to go drink some water.